Good morning, everyone from Colorado. We've had an early winter, so I hope you are doing well wherever you are. I will now introduce our esteemed speakers for today. Mike Pichichero is a physician scientist with a primary research interest in otitis and vaccine immunobiology. He's board certified in pediatrics, infectious disease, and allergy immunology. He was one of the 4 members of the discovery team at the University of Rochester that invented, patented, clinically tested, and commercialized the first HIV conjugate vaccine and meaning it's a Haemophilus influenza type B conjugate vaccine, and one of 2 who developed early prototypes of the PCV vaccines now, Prevnar. During his 30-plus year career, he has received total grant funding, more than $200 million. He's a primary inventor for 5 patents and has co-authored or authored more than 560 peer-reviewed medical journal publications. He will be our first speaker. Our second speaker is Dr. Holly Frost, who is the Enterprise Senior Medical Director of Research at Intermountain Health and an Associate Professor of Pediatric Infectious Diseases at the University of Utah. She is a general pediatrician and an expert in pragmatic and embedded clinical trials and implementation science, focusing on improving care for common outpatient infections and antibiotic stewardship. She has served as a scientific advisor for the American Academy of Pediatrics and the CDC, and was awarded the Grand Prize for Innovation by Infectious Disease Society of America for her work in antibiotic stewardship. And our third and last speaker for the first session is Dr. Roderick Venekamp, who is a practicing general physician, clinical epidemiologist, and associate professor in the Department of General Practice and Nursing Science of the Julius Center for Health Sciences and Primary Care, University Medical Center Utrecht, the Netherlands. He leads the Primary Care Infectious Disease Research Group of the Julius Center, which aims to further improve the evidence base for acute infections, including acute otitis media in primary care. Welcome all. Please go ahead, Mike.
Can you see my slides, Reggie?
Yeah.
Wonderful. Good morning or good afternoon or good evening, wherever you are. It's my pleasure to present today on the topic shown here regarding the work we've been doing in Rochester at our Research Institute. I'm going to cover 4 topics today. The current AOM microbiology, pneumococcal serotypes, and antibiotic resistance based on tympanocentesis. What we can expect will occur with AOM infections with the introduction of PCV15 and PCV20. Third, I'm going to talk about tympanostomy tubes and some work we've done that might bring into question the current recommendations for when tubes should be placed in young children. And my final topic will be to talk about otitis proneness, whether it's due to an immunity problem in young children, or is it eustachian tube dysfunction, or both. In accordance with the plans for this particular award from NIDCD, that many of the attendees are young investigators, Reggie asked me to talk about sort of my journey. My journey began in otitis media with no funding, as typically occurs with individuals in their postdoctoral or early careers. But I was able to piece together with very important colleagues some studies that put our group on the map in the otitis media research arena. This first paper, for example, Arthur Hengerer was the chief of pediatric ENT at the University of Rochester, and Les Bergash was a resident in training. And we put together a study looking at anatomic and audiologic outcomes in kids who had tube insertions versus kids back in those days who were being placed on prolonged prophylactic antibiotics. we started doing tympanocentesis and were able to look at persistent otitis media. This is a paper I published with my daughter, who decided not to go into medicine, but at the time she thought she would. Here's a paper teaming up with Robert Cohen and starting to look at shorter courses of antibiotic therapy, and that was further explored in this next paper that we published in Otolaryngology, Head and Neck Surgery. We still didn't have any funding, but we moved over to the issue of diagnostic accuracy. And you see here a number of publications in that arena, including one with Michael Poole, who is a prominent ENT physician. And we went around the country showing videos of ear examinations, and we trained providers to do tympanocentesis, and we described those findings from practicing pediatricians, from pediatric residents in training, from pediatricians that we trained in Europe. And then this other study we published in '08, where we looked at some of the problems with diagnostic inaccuracy and types of exclusion, subjects who were excluded from placebo and observational studies, that led us to conclude that it was very difficult to make this meta-analyses about this issue of observation option. Then we did receive support, first from industry and then later from NIH through R01 funding, which was primarily driven looking at the microbiology of acute otitis media, the changes that were occurring in the face of the introduction of Prevnar 7, some of the antibiotics that were being used, such as cefprozil for second-line therapy. We described in JAMA a multi-resistant serotype 19A strain during the PCV7 era that was resistant to every antibiotic approved for use in children. And then more recently, led by Dr. Carr in our group, we looked at the changing patterns of otopathogens in the nose and causing otitis using tympanocentesis. We've been fortunate to receive 2 R01s to study otitis-prone child immune dysfunction. And here's some of the papers of that work showing that kids who are otitis-prone have reduced immune responses to H. flu proteins, to pneumococcal proteins. They don't generate good memory in their CD4 T cells. They don't respond well to pediatric vaccines. And one kind of review article I wrote a few years ago about this. What are we doing now in Rochester? Well, we have 2 NIH-funded grants. We're going to look at a whole cell pneumococcal vaccine that was developed at Boston Children's Hospital by Rick Malley and Porter Anderson. Porter Anderson was my mentor for the H. flu B and Prevnar studies. And we're going to conduct a clinical trial to look at the efficacy of this vaccine in preventing nasopharyngeal colonization. We also were very fortunate to receive an R01. We think we're going to get it. We scored 2 percentile. You don't have the award until the NOAA is issued, but we've developed an H. flu lipoprotein fusion vaccine with the intent that it could be used in the prevention of acute otitis media in children. Of course, it would also prevent H. flu disease in sinusitis and acute exacerbations of chronic bronchitis in COPD adults. So we're very fortunate at the moment. Both of these are just at the beginning of 4- and 5-year funding cycles. We're looking to hire. We're growing in Rochester, New York. How do we do this in Rochester? We collaborate with community-based pediatricians. In the top, here are names of some groups that we've collaborated with and continue to collaborate with. The bolded name is the physician who is the champion at that site. So we go to these sites, we work and identify a champion who will be the site key sub-investigator, and then we train the pediatricians and nurse practitioners how to do clinical research and how to do tympanocentesis. So the top three are groups that we're active with now, and then in the bottom you see some groups that we've worked with in the past and can pull back into research as clinical-based research as we expand. I've mentioned some of our funding at the bottom here from NIH, NIDCD, NIAID, CDC, and over the years, here are three among several companies that have provided support. We have a pretty large team. Some of these people have moved on to other positions, and some names are missing here from our current group. But we have the laboratory-based activity. We have collaborations at another institution across town and ongoing collaborations with individuals also with the University of Rochester. So where are we heading in Rochester? We want to broaden the impact of otitis media research. We find in our applications and study sections, it's sometimes hard to convince study section reviewers of the importance of acute otitis media. So a strategy we're pursuing actively is to link the immune susceptibility to otitis proneness, with general respiratory infections and, in fact, asthma, so that these three phenotypes of illness might have shared immune mechanisms, that is, an endotype. We're participating in a unite team led at Boston Children's Hospital to pursue this work, and we plan to expand it. We also have shown in a couple of papers and have another one in final stages of review that links the child with otitis proneness to responding poorly to all of their routine pediatric vaccines, including their pneumococcal conjugate vaccines, an area that we intend to pursue with a grant submission in February. We have identified early life biomarkers within 3 or 4 weeks of age, cytokine profiles that identify children who will be otitis prone and who will develop poor responses to vaccines. At the same time, we continue to perform tympanocentesis and monitor the microbiology of acute otitis media, pneumococcal serotypes, and antibiotic resistance. I am forming a tympanocentesis consortium. In groups interested in this, please contact me. We have 6 centers that have provisionally agreed to join the Rochester group to perform tympanocentesis in young children as we begin to study these new pneumococcal vaccines that are coming forward in development, higher valency than 20. Most of you would know that there are 24 valent coming soon and 30 plus valent on the tail of those vaccines. So there's a call for studying the efficacy of these vaccines in acute otitis media prevention. And to do that, the FDA will require tympanocentesis studies. So consider joining the consortium. Reach out to me if you have interest, and I can give you more details. Now for my formal presentation, we published this paper on the anticipated effects of the PCV15 and PCV20 vaccines on colonization and otitis media. This came out in June in the Pediatric Infectious Disease Journal. It's a collaboration of 2 of our clinical researchers, Dr. Schultz and Sherman, and with CDC investigators, Kristen Andrico and Muwako Kobayashi. So here you see the results of that study. We had tympanocentesis in 139 episodes. About 80% of the kids in our prospective cohort got a tympanocentesis in this 2-year time frame. This is our most recent data. And so let's go over to the right-hand side. Of those 139 trypanocentesis, Streptococcus pneumoniae, abbreviated SPN, was isolated in 19%. 46% of those strains were oxacillin non-susceptible. 40% of the isolates were H. flu, remaining the number one isolate in children in the United States in our cohorts. And 27% of those isolates were beta-lactamase producing. 17% of the isolates were MCAT. All of them were beta-lactamase producing. This is already changing under PCV20. We have an ongoing surveillance program, and we are already seeing more non-vaccine types emerging in PCV20 vaccinated children. And we're seeing a higher proportion of beta-lactamase producing H. flu. And we're starting to see the emergence of different types of organisms in the nasopharynx in PCV20 vaccinated children. More on that in the future. So in this particular study spanning 2021 through 2023, we don't have a lot of isolates, but of the pneumococcal isolates from middle ear fluid, we did have a few that were PCV13 serotypes. We didn't have any in our cohort, which were in the PCV15, that is the 22F and 33F. We had a couple, 7, that are in PCV20. And then the most important thing to share with you is that serotype 35B has emerged as the number one otopathogen in our cohort by a wide margin. And we are studying that. We have 2 grants right now. One where we're looking at virulence determinants of serotype 35B as it emerged as a commensal and transitioned to a virulent pathogen causing otitis media. And we're also seeking serologic correlates of protection for 35B, 2 grants doing that work. Speaking of, well, what are these new vaccines going to do for prevention of acute otitis media caused by pneumococci? And the short answer is not much. So in Rochester, we do have in middle ear fluid about 9% of our isolates in this time frame were PCV13 vaccine failures. In terms of what PCV15 and PCV20 would do to improve our pneumococcal coverage, maybe 1% better with PCV15 and about 20% better with PCV20. Altogether, PCV15 and PCV20 will not cover more than half, actually closer to 70 or 80% of the pneumococci causing otitis media in Rochester, New York, will not be covered by either of these vaccines. You see, the problem is that when you solve one problem, you cause another, and that's serotype replacement. The pneumococcus has proved itself a dynamic and resilient organism under vaccine pressure and antibiotic pressure. The possibility of emergence has now been confirmed. There's 106 serotypes of pneumococci. So whether you vaccinate with 20 or 24 or 30, we need other approaches, which is why we're going to test a whole cell pneumococcal vaccine. And we have in the wings another serotype independent vaccine we hope to test. Regarding the pneumococcal isolates that were in AOM, about 30% were amoxicillin non-susceptible. They were susceptible to ceftriax, so more than half would be resistant to erythromycin and azithromycin. Here's a listing of the other antibiotics we tested for H. flu resistance, including antibiotics that are in the cephalosporin class that are commonly prescribed to penicillin allergic children or also children who cannot tolerate amoxicillin clavulanate. So overall, MCAT, then pneumo, then H. flu in the healthy nasopharynx, H. flu, pneumo, and MCAT in the middle ear fluid isolates. The big strain in the NP is 35B. The big strain in the middle ear is 35B. Our pneumococcal isolates are about half of them are resistant to penicillin and erythromycin, and uh, a little more than half of the antibiotics we tested show significant increasing non-susceptibility in the general time frame of 2016 to 2022. And we've identified 15 new pneumococcal strains based on whole genome sequencing in recent years. Regarding the window of susceptibility to otitis media infection, we published this paper also recently in 2023 in the journal Pediatrics of the American Academy of Pediatrics. We wanted to have some new data about what to inform the recommendations about tympanostomy tube placement. So this was a prospective observational cohort study of 286 kids. They were 6 to 36 months old. Their ear infections were microbiologically confirmed by tympanocentesis for diagnostic accuracy. Importantly, we defined a window of susceptibility as AOMs closely spaced in time with no gap greater than 6 months. What we found is that 80% of AOMs occurred during child age 6 to 21 months. That's new data. 72% of the susceptibility to recurrent infections was 5 months or less, and 97% were 10 months or less. So if you think about current guidelines, which call for the consideration of tympanostomy tubes when children have 3 infections within 6 months or 4 infections within 12 months, if you model that, it would predict that by the time we are inserting tympanostomy tubes in children, they aren't going to have any more ear infections, or at most they'll have one more. So the attribution of success for insertion of tympanostomy tubes for recurrent AOM in young children, we think needs to be reconsidered based on these data. Actually, the best predictor of the child who needs tympanostomy tube is the third bullet. If they have their first AOM on or before they're 6 months old or in that range, and they are in daycare, that child should have tympanostomy tubes inserted, and that child will benefit from the prevention of 3 or 4 more future AOMs. So this would be our conclusion suggested by these results. We did include an algorithm, it's an embedded macro in our paper, where pediatricians could look at the age of the child and, factoring in a daycare or not, predict how many more ear infections might occur. So in this cell right here, for example, the child who has their first ear infection around 6 months in daycare, we would predict they would have about 3 more ear infections after that one. So get a tube in that kid and not the kid way down in here where they're having multiple infections, especially as they're getting around 12, 15 months. The game's already over. So why do children get otitis? And the 2 answers could be generally offered, right? The literature suggests that ear eustachian tubes are flat and functionally immature, and that's why children get acute otitis media. We have been fortunately funded by NIH to spend 15 years looking at an alternative, which is that the cause of AOM in young children is primarily that the immunity system of young children is functionally immature. To get the right answer, you need to go to AI. So I went to chat and I asked them, why do children get otitis media? And the number 1 answer is anatomy, eustachian tube function. But after our work, we're now number 2, immature immunity system. We hope to be number 1 and convince you all as the years ahead transpire with our work and others. And of course, here's some other reasons that children get ear infections. So the last part of my presentation is regarding otitis proneness and some of the papers that we've published over the years showing that these infection-prone children have multiple immune dysfunctions due to delayed immune maturation, something that we've called prolonged neonatal-alike immune profile, PNIP. What do we mean by that? When we look at the immunity cells of an otitis-prone child at 6 months old, when they get their first infection, we discover that their immune cells look like they're 3 weeks old. And when we look at an otitis-prone child at 9 or 12 months, their immune cells look like they're maybe 2 months old. Gradually, the kids catch up so that by age 3, their immunity cells look more like a 2-year-old. So they're catching up as they age. What type of immunity cell problems? Well, we've got B cell problems, T cell problems, antigen. All 3 cell lines have problems in otitis-prone children, and they also have innate immunity defects. And here are 3 of the main innate immunity defects we've described occurring in the adult of these children. We have published one paper and have another one coming that AOM prone children are respiratory infection prone. So this is not due to ET dysfunction. The otitis prone child, OP, S stands for stringent, means that they had a tympanocentesis to prove they were otitis prone and were truly having these recurrent infections versus the non-otitis prone. Look how many, an average of 7 respiratory illnesses in the 6 to 18 months age range in the otitis prone child compared to the non-otitis prone. And that multifold difference persists, although it diminishes in size as the child ages, consistent with immunologic maturation. So here we're linking the study of otitis prone to respiratory prone, broadening our impact. And these kids get more lobar pneumonia. This is the average rate of lobar pneumonia in 6 to 36 months old, about 3%. 15% of our otitis-prone children got lobar pneumonia. 17% came for medically diagnosed flu and sinusitis. All of these are significant differences between otitis-prone, broadening the impact of study of otitis-prone children. Now, what about a link to asthma? We've now linked to asthma, so that's not eustachian tube dysfunction either. This is an analysis where we did a principal component analysis. IAP is infection, asthma prone. NIAP, not infection and asthma prone. And in principal component analysis, you can see how the kids just really segregated very significantly into 2 significantly different groups. And the rest of this paper goes on to show a link between children who are otitis prone at 6 to 36 months have a multifold increased risk of developing asthma by age 5 years. And not only do they have more asthma, flu, pneumonia, sinusitis, they also have more allergic rhinitis, but they don't have skin allergy or food allergy more often or other types of infections. So this really is a mucosal phenomena driven in the respiratory system based on the work we've accomplished so far. So lastly, I want to talk to you about linking otitis-prone children with low vaccine response. We define this as low vaccine response, LVR, are kids who have below protective immunity responses to 2/3 of vaccines that we test, including the ingredients of DTaP vaccine and HIB vaccine. So I'd like to close by recognizing the tremendous contribution of patients to our work. And here's a set of twins that were in our studies. I couldn't tell these identical twins apart by looking at them until I realized that this twin always put those two fingers in his mouth, and this twin put those two fingers in his mouth, and that's how I figured out which was Josh and which was Jack. Thank you very much.
Thank you, Mike. That was wonderful. Holly, you can start anytime. And congratulations on the funding. That was great.
We're very grateful.
There we go. All right, I'm hoping you can see and hear okay. If not, please give me the thumbs down. Perfect. All right, so I'm going to shift gears a little bit, and I'm going to talk with you about antibiotic stewardship and acute otitis media. I don't have any disclosures relevant to this. We do get funding from a lot of different agencies and have some other patents and things related to otitis. So I'll share a little bit about my research journey, not specific to otitis, but just in general. So I would say that my path into research has been a little bit non-linear. So I grew up in this teeny town in northern Wisconsin, where my dad owned an archery store. The amount of snow that we get is probably just slightly less than what Michael gets up in Rochester. But I really went into medicine because there's such limited access to medical care, and the quality of care was really poor. And so I went to medicine with the idea of thinking about how do we improve the quality of care and access to care for people who are outside of metropolitan areas. And then through a long and not very exciting journey, I ended up at Children's Hospital Colorado and started doing some clinical research in emerging infectious diseases. And so decided at that point that I was really interested in emerging outpatient infections rather than inpatient, and chose to do the path of clinical general pediatrics, but doing research in infectious diseases. And then after training was offered a physician scientist position up at Marshfield Clinic Health System, which is a health system that has 3 hospitals and about 52 rural clinics located in northern Wisconsin. And what I learned from that experience was really how to do clinical research and especially clinical trials in rural and traditionally difficult to reach populations, how to embed some of the clinical research into those particular clinics. And if you can see here, this is a picture of where I clinically practiced, which is actually on an island called Venekamp. I was then recruited back to Denver Health and University of Colorado, where I served as Senior Director of Center for Health Systems Research and Office of Research. And Denver Health is the safety net for Denver, and so really serves a highly disadvantaged population. About 90% of kids have some type of public insurance, and about 75% of kids are from racial or ethnic minority groups. And so a key aspect of doing research there was really thinking about how do we build equity into the work that we're doing, and how do we make sure that we are establishing trust with populations that traditionally don't participate in clinical trials. And then more recently was recruited to Intermountain Health. And at Intermountain Health, we have about 400 clinics, 33 different hospitals across 7 states, and have 1 and soon to be 2 children's hospitals. And so a huge portion of my role now is really thinking about how do we do research across the entire system to make sure there's access for clinical trials. But I think that these experiences have really taught me 3 things. And so the first is that most patients do not receive care at academic centers. Most of the care that we provide in this country is really in community-based centers. And unfortunately, research is often inaccessible to people that are outside of those centers, even research that they could directly benefit from. And then research findings from academic centers are often not generalizable. So the patients we see at children's hospitals are inherently different than the patients that we see in most community-based settings. And I can get, in a quality improvement or stewardship intervention to work really well at a children's hospital. That doesn't mean it's going to translate to a clinic up in Billings, Montana. So it really has forced us to think about how do we generate evidence in the real world, and how do we implement research back into the real world. And then my journey through research has been a little unexpected as well. So I've been both fortunate, I guess unfortunate, to have a child who's benefited tremendously from embedded research. And so in February of 2020, I'd actually enrolled both of my kids into a clinical trial that was looking at autoantibody screening for type 1 diabetes as healthy controls and then have learned that my youngest had 3 out of 4 autoantibodies for T1D. And within about 2 weeks, they actually fully converted. Now, I don't know what your recollection is of February and March of 2020, but it turns out that is a bad time to need insulin for type 1 diabetes. But the advantage is because he was enrolled in this clinical trial, we knew. And so he actually was fully diagnosed before he needed insulin and never needed medical care or went into DKA. But what this really highlighted to me is that, for type 1 diabetes, autoantibody screening is accessible almost exclusively through research studies. So if you're outside of an academic center, your child is unlikely to get tested. And the FDA-approved treatment we have to delay onset is only accessible to kids who are picked up at the phase where they develop autoantibodies but don't yet need insulin. And so it really highlights the value of some of these embedded trials in improving access so that we can reach a larger portion of kids who could benefit. So this is a little bit about the structure of my research team. So we have kind of a core team for our research, and then we have 4 teams that are led by different experts in the area. So we have a quantitative team that does a lot of our basically quantitative analysis and RCT analysis. We have a qualitative team that's led by Dr. Debbie Reinhardt, who is a mixed methods expert. We have an implementation science team led by Sonha O'Leary, who's an expert in implementation science, and Leisha Anderson, who does a lot with QI with American Academy of Pediatrics. And then an informatics team, which is led by Dr. Corey Hussein. And so when we run projects, we functionally will bring in grants, and then all of these teams will work on their respective components and then bring them back together. And we do research right now across about 10 US health systems. And then for all of our studies, we have national stakeholders from CDC, AAP, and Pew that contribute to the study design and then work with us throughout the study. So what I'm going to really talk about today is stewardship for AOM. And I'm going to focus mostly on kids who have uncomplicated and not recurrent AOM. And I think it's important to recognize that this is the most common reason that kids are prescribed antibiotics in the US. So if you look at this chart on the right, you can see about a quarter of all antibiotics for kids are prescribed for AOM. And each year, that's about 5 million kids prescribed 10 million antibiotic prescriptions. And they're exceedingly common. So by the time kids are 3, about 60% have had one or more infection, and about a quarter have had 3 or more infections. And so if you're a child in the US diagnosed with an ear infection, there's national guidelines, which are now over a decade old. But what they essentially say is that you should be diagnosed using tympanic membrane bulging. Immediate antibiotics are recommended for most kids, but watchful waiting can be used in select cases. Amoxicillin is still recommended as first line for most kids, with amoxiclav recommended as second line or as first line for some certain children. The duration of therapy depends on how old you are and if you have tympanic membrane rupture, and then all kids should have pain control. But what we know is that if you're a child in the US diagnosed with AOM, there's actually about a 30 to 50% chance that diagnosis is wrong and you don't actually have it. But nevertheless, you will almost assuredly still be prescribed an antibiotic. You will probably be told to take that antibiotic right away, as opposed to receiving a delayed antibiotic where you're told to take it if your child worsens or if your child doesn't get better in a few days. There's a decent chance that it will be a broad spectrum antibiotic, and you might be thinking, well, that makes sense, it would be amoxiclav. But ceftonir has become the new favorite broad spectrum antibiotic used by primary care physicians and urgent care docs, and is quickly replacing azithromycin. And no matter how old you are, or how ill or not ill you are, you will almost assuredly receive 10 days, and this includes for kids who are 2 and older. And at the end of the day, we have no idea if any of these kids have actually had any conversation about how they can control their pain. And unfortunately, the situation that we're seeing, at least in the US, has been either the same or seems to be worsening over time in terms of prescribing. So this was a study that was published in 2022. And the bottom line looks at the proportion of kids with respiratory diagnoses who are diagnosed with AOM. And the top line looks at the proportion of kids with AOM who are prescribed an antibiotic. And so what we had hoped to see is after the 2007 and 2013 AEP guidelines came out is a reduction in both of these, more kids using watchful waiting and more kids diagnosed using stringent criteria. And unfortunately, we've actually seen an increase in both of these. And so It's also interesting to note that there are 3 lovely conducted efficacy trials for AOM that were conducted during the same time period, and those efficacy trials did not seem to profoundly change prescribing. When we look at antibiotic duration over time, these are data that we pulled from IBM MarketScan, which is a payer database that covers large regions of the US. And what we found is that predominantly every kid, no matter the age, tends to get 10 days. In fact, in younger kids, we prescribe 14 days with almost similar frequency to prescribing 7 days. And then these are data from one of our baseline data from one of our clinical trials. And you can see that maybe there's a slight trend for shorter durations through time. These are for kids that are over 2, but predominantly almost all of these kids continue to get 10 days of therapy. And this has real consequences for kids. So we know that antibiotic resistance has been a growing problem. Adverse drug events are relatively common among kids who receive antibiotics and are more common for kids that receive broad versus narrow spectrum antibiotics. There's an association with early antibiotic exposure and chronic diseases later in life, especially autoimmune diseases. That association is dose dependent. So the more doses you get, the higher the association. There's been an increase in community-acquired C. diff diarrhea infections. There's higher costs, and then unnecessary antibiotics have been directly associated with reduced pediatric quality of life. And so when we think about antibiotic exposure versus benefit, I think it's important to think about this in the broader context. So if we look at a usual care setting and the number of kids that we expose to antibiotics versus benefit, you can see that for about 100 out of 100 kids that receive antibiotics for ear infections, we would expect for about 84% of these kids that there would be no benefit. These kids would do fine regardless of if they did or did not get an antibiotic. We also have about 11 kids where there probably is no benefit, and these kids are going to feel crummy no matter what we did if they did or did not get an antibiotic. And then we have these 5 kids who are probably going to have benefit. So we expose a lot of kids to antibiotics for benefit for a few kids. Now, if we think about this in the context of kids who are younger, who are more likely to have bacterial infection because they were stringently diagnosed, that number needed to treat for benefit goes down, but it's still that most kids that we're treating are going to not have benefit, and we're exposing the others to antibiotics. So we just need to be cognizant of that and really think about how do we get antibiotics to the kids who need them while avoiding the consequences for the rest of kids. So one of the core questions that we've been really trying to work on is this idea of why hasn't prescribing for AOM improved, and what do we actually do about this? And one of the ways we've tackled this is by running pragmatic trials. And so this is a quote from an author who's not a scientist, but a quote that I like. And it says, "Pragmatism is not simply an effort to be practical. It's a sprawling set of philosophical arguments, but the basic idea goes, start from the end and work backwards. Substitute the phrase, is it good with does it work? Do what must be done without the benefit of your preferences." And I think the last part of this is really key, because I think that we all know in an ideal world how we would like people to diagnose AOM, what we want them to do, and how we want them to do it. And the problem is that that simply just hasn't worked. And so we need to think differently about how do we actually improve care for kids, recognizing that what we ideally would like them to do may not align with what's going to happen. But let's look closely at where are antibiotics prescribed and by whom. And I'm going to apologize that this is a little bit US-centric. So these are data that were pulled from one of our IBM MarketScan studies. And you can see that most kids with AOM are actually prescribed antibiotics in an office setting, but about 10% happen in urgent care or emergency department settings. But the table on the right, I think, is really important, which is that only about half of these prescriptions are from pediatricians. So roughly half of people or kids seen for ear infections and prescribed an antibiotic are seen by somebody who's not a pediatrician. And what that means is if we really want to improve care, we have to think about how do we work with, a colleague who's seeing adult patients where their priority might be the patient next door that's having an MI or a stroke, as opposed to just targeting the pediatric population. And then we recently did a meta-analysis, and we looked at if we could get people to just follow the AEP guidelines or to follow guidelines from Europe, and we use the UK guidelines, the NICE guidelines, as kind of the representative for some of our European guidelines, how much would that reduce antibiotic use And you can see that if we could get providers to just align their practice with even current guidelines, that with the AAP guidelines, it would cut antibiotic use almost in half. And if we aligned with the ones from the UK, it would cut it by about 2/3. And so there's a huge gap there in terms of what we're doing and even what is considered guideline non-concordant. But where is the issue? Where are people not aligning with guidelines? And so we looked at kind of 3 different categories. Is the issue that they're not diagnosing AOM correctly? Is it that they're not using the right duration? Is it that they could be using watchful waiting but are not? And what we found is that by far the most common reason that we see unnecessary antibiotic days is based on diagnosis. And so by volume, most of the inappropriate antibiotics we see are because the kid doesn't have AOM to begin with. But you can see that even if we take into account the fill rates of delayed antibiotic prescriptions, which we did here, that there's huge opportunities in all of these areas. And so we really have kind of 3 targets that we can use to think about stewardship intervention. This is a meta-analysis we did that looked at 15 studies in the effectiveness of different interventions targeting these specific areas. And unfortunately, though we know that diagnostic accuracy is where most of the volume of unnecessary days of therapy come from, the interventions focused on diagnostic accuracy have not shown particularly high effectiveness and have not been broadly implemented compared to some of the others. In contrast, interventions focused on watchful waiting or duration of therapy are much more effective. And so if we actually take these into account, so we look at the opportunity to align, how many unnecessary days of antibiotics are from each of these different categories and the effectiveness of the different interventions, what we find is that implementing interventions for watchful waiting and durations of therapy actually may have higher potential to improve care and reduce overall unnecessary prescribing compared to those related to diagnostic accuracy. And so we've really focused on these 2 areas here. The other challenge with diagnostic accuracy is that a lot of the tools that we know work really well in stewardship, so things like giving feedback to clinicians on how their prescribing is compared to their peers, using electronic health record system nudges, work really well for watchful waiting and duration of therapy, but are almost impossible to roll out for diagnostic accuracy. And so there's some logistical challenges with interventions in that diagnostic accuracy space. So based on these, we vetted 2 different kinds of interventions. One's focused on duration and one's focused on watchful waiting. And so our goal for this was really to see, can we get these interventions to work within a fairly controlled environment, and what would be the estimated effect size if we were to do a clinical trial in these areas? And so the first one we did was focused on duration, and we implemented 2 interventions. So the first one was based on the CDC core elements of outpatient stewardship. And this included education for clinicians, feedback on their prescribing compared to their peers, electronic health record tools, and access to clinical care guidelines. And we found that this intervention was actually highly effective. And so you can see it very rapidly improved care and actually increased the use of short antibiotic durations for kids 2 and older by about 75 absolute percentage points. The second one that we rolled out was one that we thought that any health system could do, no matter what resources you had. And so essentially all we did is we changed the prescription field within the electronic health record so that when you ordered something like amoxicillin, there was a button there for 5-day duration and a button for 10-day duration. There was some text at the top that told you what duration to prescribe for kids of what age and what severity of symptoms. And we found that just by doing that with no education or anything else, that increased the use of shorter antibiotic durations by 49%, which I would argue for 2 hours of an IT person's time to change it was pretty remarkable. Now, the challenge is that the top one was implemented in peds clinics. The bottom one was implemented in family medicine, so they're not comparable. And we did look at treatment failure and recurrence afterwards and found that they were the same between kids who got short and long durations, and also the same between kids who were in each of the different interventions and the baseline period. But there were a few things we really learned from this. And the first was that this was easy. Nobody seemed to care what duration was prescribed. Parents didn't care and clinicians didn't care. And it was highly sustainable. So we can measure this long-term, and even once we removed any of the extra support besides the EHR changes, the rates of short guideline or short antibiotic durations persisted. The second one we rolled out was one focused on watchful waiting. We did this in conjunction with AEP and CDC, and we implemented an intervention in 8 practices in Colorado, and then it was replicated in 6 practices in Virginia. And this one was also based on the core elements of outpatient stewardship, and it worked. So we increased watchful waiting by about 27% using the gold standard. But what we learned from this is that this was a really heavy lift. So you can do this, but it takes a lot more work. And so there were a few key things that we figured out we had to do in order to make this successful. So one is that there had to be buy-in between clinicians and parents, and we had to be able to measure outcomes at the parent level. So what we really needed to know was, were the antibiotics taken? And the biggest issue we ran into with this is you can use watchful waiting, but if the parent then just goes and seeks care somewhere else, or they fill a delayed antibiotic prescription right away, then you're really not decreasing the antibiotic exposure that kids have. And so we knew that this was going to be a heavier lift in order to run a clinical trial. So when we look at parent satisfaction, we've done a lot of work on this because it seems to be integral to being able to be successful in these interventions. What we find is that parents overestimate the risks of not treating, including thinking that if their child does not receive an antibiotic right away, they may have permanent damage and or die. They underestimate the risks of antibiotics and tend to think of them as completely benign. And what they really care about is pain control. They want to know a contingency plan. What do I do if my child doesn't get better? They really want to participate in the decisions that are being made about their child's care. And we found that, again, 89% of parents either want the shortest duration of antibiotics possible or whatever is recommended by the provider. And so this is a kind of a constant tension that we have in our team when we're deciding clinical trial design, which is this idea between explanatory and pragmatic trials. So in explanatory trials, we're really looking at, does the intervention cause the effect, and if so, by how much? And so in order to determine that, we're really doing this in a very highly controlled environment with low bias. But the challenge is that what we really care about in our team are, how does this work in the real world, and how do we actually scale this and replicate it? And so we tend to do pragmatic trials, which are the findings generalizable to other settings? What's the external validity? Are they representative and replicable? Recognizing that there's a higher risk of bias and that we need to be aware of that and we need to account for it. And realizing too that every trial is on a scale, right? So none are really truly explanatory or truly pragmatic. They tend to lie in between. So I'm going to talk briefly about 2 of our pragmatic trials that we have going on. The first one is called Relax. It's funded by ARC. And this one is focused on reducing unnecessary long durations of antibiotics for kids 2 and older. And we're aiming to answer 2 questions. So the first one is, which health systems interventions reduce unnecessarily long antibiotic durations? And the second is, what are the implementation outcomes? So how could we do this in another clinical setting? And so this study is being run among community-based clinics at Vanderbilt and WashU. We have 46 participating community clinics, which includes some retail urgent care and primary care clinics. And clinics are randomized to either get a low intensity intervention, which is the one with the electronic health record changes that we think any health system in the US could do. And the second one is randomized to get a gold standard, which is based on the CDC core elements of outpatient stewardship and includes all the stuff in the low intensity, plus feedback to clinicians and their prescribing compared to peers. And in order to do this, we do a hybrid implementation effectiveness design. And so in the pre-implementation phase, we do mixed methods analysis using a framework called PRISM, which is an implementation framework. And this helps us understand what is the baseline and what changes do we need to do to adapt the intervention so we can actually implement it. We then, throughout the study period, monitor for adaptations using a FRAME-IS framework. And this helps us to understand what the internal validity is. So do we maintain the actual integrity of the interventions, even though health systems adapt them? And then we use REAIM on the back end in order to analyze implementation outcomes. And so these are some of the work from the pre-implementation phase. And you can see here that these health systems perform a little bit better in terms of durations of therapy, but we still see that most kids are getting 10-day durations. And then this we looked at, which we thought was pretty interesting. And the question was, does an individual clinician prescribe a different duration based on the patient they're seeing? Or do clinicians prescribe differently within a given practice? And what we found, and what you can see from all these narrow bars, is that if you are in a practice, you almost certainly prescribe similarly to the other people within your practice. And most clinicians actually prescribe the same no matter what the patient is they're seeing. So people tend to get their preferred duration that they always prescribe and simply prescribe that duration repetitively. The exception being some of these longer bars that you can see here where there's more heterogeneity within a clinic. We also did qualitative interviews of clinicians and focus groups of parents. And what we found from these is that most clinicians said that they use 5 to 7 days, even though when we look at their quantitative data, they're using 10. So they have a misperception about what they're actually prescribing. Many said that 2 to 3 more days was no big deal. They routinely said they never used watchful waiting, and some were skeptical of doing a short duration, like a 5-day duration. We heard a lot that people would deliberately prescribe a longer duration in case patients are non-compliant. So, I'll prescribe 14 days in case they decide that they're only going to take 10 and take a shorter amount. They cared a lot about prescribing consistency, and if they were given feedback on their prescribing, they wanted it to be anonymous. From parents, we heard that they had always been prescribed an antibiotic. Most had had a childhood side effects that they attributed to the antibiotic. They routinely said that options for management were never discussed with them. They'd be fine with whatever duration. And they felt very strongly that side effects and risks, as well as benefits, should be discussed by the clinician with them. And many of them were getting the information when they went to the pharmacy, and it was discussed by the pharmacist, which was a big issue. The second clinical trial we're doing is called Disappear. And this one focuses on watchful waiting, is funded by PCORI. And we have two outcomes here. So the first one is which health systems intervention increases the use of watchful waiting, and the second, again, are implementation outcomes. And these interventions are a little different. And so the first intervention is really based on the CDC core elements about patient stewardship. The second intervention is an intervention that includes that and includes shared decision-making based on some of the qualitative work that we've done with parents, indicating that one of the key issues here is really a lack of communication between clinicians and parents about risks, benefits, and including parents in decision-making. And this study is being rolled out, includes partners from Mayo Clinic, Denver Health Alliance Chicago, which has Near North and Erie clinics, and then Intermountain Health. And again, we're using the same hybrid implementation effectiveness design. But one of the keys for this that's different is that we have to do direct parent-reported outcome measures. And so one of the things that I love about this trial, not administratively, but I think will be great long-term, is it's going to help us to really understand kind of this black box of what's happening in the course of care for kids with ear infections. So we're using a combination of EHR data, patient surveys, and manual chart abstraction. And it will help us understand, how sick was the child at home before they came in? Why did the parent decide to bring them into the clinic in the first place? And what had they already done at home for the child? When they go to the clinic, we'll be able to see where they went and who they saw. We will be able to see what the documented ear exam was. Now, this may not represent what the actual ear exam is, but it's at least what the clinician thought they saw or what they wanted to document that they saw. We'll be able to understand what the conversation looked like between the patient and the clinician, or parent and the clinician. We'll know what the prescribing was. Was there no antibiotic, immediate antibiotic, or delayed antibiotic? And then based on that, did the parent fill the antibiotic, and if so, when? So if they're prescribed a delayed antibiotic, did they just walk over to the pharmacy and fill it anyway? And then did the parent actually give it to the child? So we've heard from many parents that they pick it up at the pharmacy, they keep it at home in case they need it, but then they don't actually give it to the child. We'll know how often that happens. And if they did give it, how much and for how many days? And then finally, we'll be able to know the outcomes of the child. How was the child's ear pain? What were the adverse drug events? And then in addition to that, we can measure all the implementation outcomes for the actual interventions. And so key points is that antibiotic use remains a substantial problem for AOM. Interventions targeting duration and watchful waiting are effective, but they haven't really been adequately scaled. Interventions and diagnosis in usual care settings have been limited to this point, but there's potential there. And much of the care for AOM in acute care settings remains a black box that we're hoping to understand better. All right, thanks, guys.
Thanks, Holly. We're ready for you anytime, Roderick. Holly, we really need more people like you with boots in the ground. That's a very expansive work with a big network. Congratulations.
Okay, I'm very happy to present my work on the medical management of AOM-related ear pain and ear discharge. I've been introduced by Reggie. I don't have any conflicts except for governmental funding. And to start with my research journey, I'm a GP by background. And of course, I first had to complete my specialization training, which started in 2008. And at the same time, so I combined my GP specialization training with a PhD studentship on steroids for acute sinusitis, which I completed in 2012. And alongside, I also completed a master in epidemiology at the University Center of Utrecht. From then on, I combined my GP specialization training with one-day research as a postdoc researcher by Anne Schilder. Probably you all know her, and Professor Dan Roiseau, who is also a GP and head of the GP specialization training in Utrecht. Then I completed my GP specialization training in 2014, and I combined working as a practicing GP first as assistant professor based on a personal grant on acute sinusitis and sore throat and how to predict individual antibiotic benefit based on large individual patient data meta-analysis. But I also, of course, with Anne Schilder as my supervisor, did a lot of research on acute otitis media, which I will come back later. And in 2020, I became an associate professor at the University Medical Center Utrecht and lead of the primary care infectious disease research group, which consists of 4 colleagues who are assistant professors. Lieke van der Velde. She mainly focuses her work on antibiotic stewardship and large pan-European studies, trials as well as observational studies in the field of respiratory tract infections. Tamara Patil, who's also a GP by background, she's mainly focusing her work on urinary tract infections. Lonneke van Vught, who recently joined our group as a GP, who focuses her work on respiratory tract infections and sepsis. And Feike Loots, who is an acute care physician, and his work mainly relates to sepsis and acute care, mainly the hospital at home concept. Currently, I'm supervising 9 PhD students, 2 who relate to AOM. 1 is focusing on recurrent urinary tract infections. 1 is studying the link between respiratory tract infection and cardiovascular diseases. 1 is studying the RSV burden in primary care. And 1 is currently setting up a trial on the diagnosis of acute appendicitis in primary care and whether we can reduce the referral rate and without delaying the diagnosis of appendicitis based on a prediction rule. 1 of my students is focusing on the telephone triage of patients with shortness of breath who call the out-of-hours services in primary care and how to optimize this triage. And 2 students are focusing on remote monitoring and home management of respiratory tract infection patients. So it's a broad scope, and not only is my work focusing on otitis media, but of course, for this presentation, I will focus on acute otitis media, which, as you all know, is a prime reason for doctor consultations, not only in the US, but also in Europe and also in the Netherlands. Although there was a slight or I think a major decrease in the incidence of acute otitis media in the COVID-19 pandemic, we also observe, and hopefully we will publish in due course, that the incidence of AOM is increasing again and nearly back to the pre-pandemic levels. So it's still a very relevant condition. And ear pain is the key symptom for parents and children. And of course, systemic analgesic is therefore the cornerstone of AOM management. And analgesics are widely recommended in clinical guidelines worldwide to alleviate the symptoms, but at least according to some studies, they are not routinely recommended in daily practice, and therefore we conducted a study to try to improve the use of analgesics. What about the evidence base of systemic analgesics? It's rather limited. There is one trial who compared paracetamol versus placebo and showed that paracetamol did lead to a reduction in pain at 48 hours, but the same applied for ibuprofen versus placebo. And there doesn't seem to be a lot of difference between paracetamol and ibuprofen. But immediate comparison is very low, and the add-on of ibuprofen to paracetamol is really unknown. Currently, there are hardly any studies who are compared ibuprofen plus paracetamol versus paracetamol alone. So in all, we thought it was important to try to improve the pain management in childhood acute otitis media in general practice. Also, with the aim to reduce the antibiotic rate ultimately, but mainly to improve symptoms and improve patient-reported outcomes. So one of my PhD students who finished his PhD already conducted a cluster randomized controlled trial of a GP-targeted educational intervention. And as also Holly said, we are also very much into pragmatic trials in primary care. So mainly all of our trials are more or less pragmatic from nature. So we did a cluster randomized controlled trial in 37 GP practices, and we randomized the GPs to either usual care or the intervention group, who received a multifaceted educational intervention, consists of a blended learning module for GPs, a parental information leaflet provided by the GPs, with information about how to use the analgesics at which dosage, because we all know that ibuprofen is hardly used, but paracetamol, if used, and the dosage is most of the time not the recommended dose. So we really stress the importance of getting an appropriate dose of paracetamol to the children. And instead of only recommended, we also asked the GPs to prescribe the paracetamol and ibuprofen, with the idea that if you prescribe it at a certain dose, that it's more likely that also these children really receive the higher dose. We included children aged 6 months to 10 years of age with AOM, at least a GP diagnosis of AOM, and ear pain. So all children should have ear pain at diagnosis. This is the baseline table. As you can see, it's fairly well balanced. Children were aged more or less 40 months. There were some slight differences between the groups. Slightly more recurrent AOM in the intervention group, and slightly more bilateral AOM in the usual care group. And as you can see, is more or less a result already at the bottom of the table that children were prescribed antibiotics in 37% in the usual care group versus 23% in the intervention group. And I have to say that in the Netherlands, it's among the lowest prescribing countries in the world, I think, especially for AOM. But most of the time we see a prescription rate of 50 to 60% in daily practice. So this is rather low, also in the usual care group. But at baseline, at least, the prescription rate of oral antibiotics was lower in the intervention group. So what about the results? For the results about the analgesics, remarkably high number of analgesics recommended, also in the usual care group. This either reflects that apparently in the Netherlands, analgesics are recommended quite often to children, also in usual care, or that those who are assigned to usual care are more likely to prescribe because they are interested in the topic, although we didn't explicitly mention anything about the intervention to the usual care group. But you can imagine that participating in a trial will also do something in your daily practice. So 92% of GPs in the usual care group versus 100% in the intervention group recommended analgesics. But we observed a much higher rate of ibuprofen use in the intervention group, and also, at least at baseline, slightly higher, but during the days, higher doses of paracetamol in the intervention group, although still suboptimal, I would say. So what about the outcome, the primary outcome, mean ear pain score? So we thought that increased use of analgesics would also lead to less ear pain, but apparently in our trial, this wasn't the case. So as you can see from the figure, which shows really depicts the course over time, there is hardly any difference between groups in terms of ear pain over the 7 days. And remarkably, a similar graph was shown by Paul Liddell, comparing immediate antibiotics versus delayed antibiotics. So, yeah, I think the graph really depicts the course of disease, but apparently no difference in the course and the level of ear pain between the groups. What about the antibiotics, which was a key secondary outcome? Yeah, we observed a lower rate of antibiotic prescription at baseline, but during the trial, repeat visits were higher in the intervention group and also subsequent antibiotic prescriptions. So in the end, there was no difference in antibiotic prescription and probably also antibiotic consumption between the groups. And remarkably higher repeat visits in the intervention group. So in conclusion, this trial showed that such an intervention led to similar pain levels in both groups, despite an increase in ibuprofen use in the intervention group. The paracetamol was higher dosed in the intervention group, but still suboptimal. And ibuprofen as an adjunct to paracetamol seems to have no added value. Yeah, now you can speculate about the intervention group, the observation of the increase in GP visits, repeat visits, and subsequent antibiotic prescriptions. What are reasons for that? It might be that there is a lower threshold for reconsultation in the intervention group because of the parental leaflet explaining when to reconsult, etc., so that they just were more aware that they have to reconsult. It might be an effect of a lower baseline antibiotic prescription rate in the intervention group. Not sure, but might be. The between group difference in parental perceptions might also, of course, be an option. And yeah, at last, I would point out that ibuprofen use might also have a negative effect rather than a positive effect. We know from other studies, there's trial evidence and observational evidence that NSAID use for respiratory tract infections might do more harm than good. We recently published a BMG Open that for respiratory and urinary tract infections, GPs who tend to prescribe NSAIDs more often at a practice level, but also at an individual level analysis, that relates to higher GP repeat visits, but also higher hospitalization rates among these patients. Of course, confounding by indication in such a study and also in this study cannot be entirely excluded, but still, I think there's something there. So we should be aware that NSAID use for acute infections might not be that beneficial and potentially harmful. Then I would like to continue with AOM-related ear discharge. We can, at least for the acute ear discharge, differentiate between those related to tympanostomy tube and those without tympanostomy tubes inserted. So the ear discharge due to spontaneous tympanic membrane perforation or an eardrum tear. Regarding the tympanostomy tube otorrhea, Mike also touched upon this. It's one of the most common surgical procedures in children. And we, in an observational cohort study, showed that 2/3 of children with tympanostomy tubes develop at least one episode of acute tympanostomy tube otorrhea, so that's quite common. And at the time we conducted our study, there was inconsistent guidance and variation in clinical practice. GPs tend to prescribe, at least in the Netherlands, oral antibiotics, also supported by the guideline at that time, while end surgeons nearly always treat them with topical antibiotics. So we conducted a pragmatic trial of treatment for acute tympanostomy tube otorrhea. It was a pragmatic open-label randomized controlled trial with 230 children randomized aged 1 to 10 years, recruited by ENT surgeons and by GPs. And we divided them randomly into 3 treatment arms: antibiotic steroid ear drops for 1 week, oral antibiotics for 1 week, and we used amoxicillin clavulanate. And we used, for the antibiotic steroid eardrop groups, the hydrocortisone bacitracin colistin eardrops, which is only available in the Netherlands and France, but I think in terms of coverage, more or less similar to other broad-spectrum antibiotic steroid eardrops. And I think the novelty of this trial was that we also had a group who had an initial observation period for 2 weeks, so no treatment. The baseline characteristics of this study, also no large between group differences. The age, they were over 4 years of age, so this is an important thing to consider. So these are older, and the median duration of otorrhea was more or less 3 days. So really acute onset of the otorrhea. At that time, the Haemophilus influenza was already the most dominant strain detected in the ear discharge. What about the results? We really observed a low treatment failure rate in the topical antibiotics, topical corticosteroids, antibiotic corticosteroid drops, and a much higher percentage of failure in the oral antibiotics, and the highest percentage of failure in the initial observation group, corresponding to a number need to treat to benefit. And this is regarding the otorrhea observed by a clinician at 2 weeks. Number need to treat of 2 and 3 versus initial observation and oral antibiotics respectively. And this is the survival curve, and you clearly can see for the otorrhea as reported by parents in the diary, so not the primary outcome, but a secondary outcome as reported by parents over the 14 days, a clear difference between the antibiotic steroid eardrops and the oral antibiotics and the initial observation, with initial observation lasting in 15% more than 2 weeks. As you can see also here, the median duration of the initial episode when you don't do anything is 12 days and 4 days for the topical antibiotic groups. And remarkably, a higher number of days with otorrhea also during 6 months of follow-up in the oral antibiotics and the initial observation group. So it doesn't only work for the first episode, but also as a prolonged effect during 6 months in terms of repeat otorrhea episodes. We didn't observe any serious complications of adverse events in any of the groups, and the topical antibiotics were associated with pain and discomfort in 16 children and local rash in 2 children, whereas the oral antibiotics led to gastrointestinal symptoms in 80 children and rash in 3 children. So we concluded that topical antibiotic corticosteroids are clinically superior to oral antibiotics in initial observation in children with tympanostomy tube otorrhea, and that initial observation is not a viable management strategy. It leads to persistent ear discharge at 2 weeks in 1 in 2 children and more days with ear discharge in the following months. And then we thought, what about cost? So this is also, of course, important. So we did a cost effectiveness analysis. And here you can see in the cost effectiveness plane clearly that it's not only clinical superior, so in the right part, but also economically superior at least in almost all of the scenario for the initial observation, 99.4%, but also in 70% of the scenario when comparing to oral antibiotics. So it's predominantly in the right bottom part of the plane. And we dove also a little bit more into the antibiotics use at 6 months in this cost-effectiveness analysis results. And what we observed is that you do not only reduce the cost, but also the total amount of antibiotic use during 6 months when you treat them with topical antibiotics. So you can wait, of course, and then it lasts for 2 weeks and half of the children will get better. But in the end, more antibiotics will be consumed by these children, and they are also worse in terms of prognosis. So it's really not a viable treatment strategy to refrain from treatment in these children. So therefore, and there's also a Choosing Wisely campaign, don't prescribe oral antibiotics for uncomplicated acute tympanostomy tube otorrhea, but treat them with topical antibiotics directly. And then, of course, the saga continued. We thought, okay, then we have provided the evidence for the tympanostomy tube otorrhea, but there's also a group of children who don't have tubes, but still have discharge. And remarkably, these children have a higher rate of pain and or fever at 3 to 7 days compared to those who don't have discharge. I think it's a common belief that children who have discharge are relieved from pain and fever, so you don't have to do anything. There's clear evidence that they tend to have a worse prognosis, so that's really a subset of children with a worse disease. But the median duration of air discharge without tube is 4 days compared to 12 days, what I said before, in those with tube. So this led us to the hypothesis that you cannot apply the evidence for the tubes directly to those children because apparently the discharge lasts less longer. So the topical antibiotics might also have a smaller time window to work for these children. And we know that oral antibiotics in this group children work. At least they are better than placebo or no treatment to relieve pain and or fever at 3 to 7 days. So then we did a research in the literature about the evidence for topical antibiotics in this group of children, and there's just no evidence. And therefore, we designed a randomized controlled non-inferiority trial comparing topical with oral antibiotics in children who have AOM and ear discharge and pain and or fever. So this was the group of children. So those who didn't have ear pain and or fever at baseline but had discharge couldn't participate in the trial. We did an open label parallel group randomized control non-inferiority trial among 52 general practices in the Netherlands, comparing the same drops as before with oral antibiotics, and we now use amoxicillin 50 milligrams. So in the Netherlands, we tend to start with 30, then it was 40, and now we're already at 50 milligrams of amoxicillin, which is the recommended dose. Compared, I think in the US, it's 90 milligrams due to the susceptibility of the pathogens. But as you can see, the doses also is increasing in the Netherlands already. So we used 50 milligrams for 1 week. But unfortunately, the trial was terminated early due to study medication supply issues. And problems due to the COVID-19 pandemic. So we would like to have included 350 children, but only were able to recruit 58 children. Of those who were recruited, we were able to have the primary outcome mainly all children. So the follow-up was really good, but the number of participants was fairly low. In terms of baseline comparison, yeah, the groups, there were slight disbalances due to, I think, mainly the group size, so 27 and 38. But I want to point out that these children are much younger than those with tubes, so 28 months. And the duration of AOM discharge, so the discharge was also still 2 to 3 days, so really acute onset. Most of these children had pain. Some of these children also had fever. And what did we see? Although the numbers were and are low, we saw that the drops didn't work that well in this group of children. So there was a higher resolution rate of ear pain and fever in the oral antibiotic group compared to the topical antibiotics. And we said, okay, we are happy to accept a non-inferiority margin of 15%. That leads the lower limit of the confidence interval should not exceed the 50%. But as you can see, also the point estimate already exceed this interval. So yeah, at least from our data, as you can also see in the Kaplan-Meier curve here, is that the oral antibiotics tend to work better than the topical antibiotics. In terms of treatment-related and serious adverse events, no serious adverse event in both groups, but we saw that there was difficulty during administration in 60% of the topical antibiotics reported by parents, and also quite a high number of local discomfort during administration. So in conclusion, there was early termination of the trial, limited sample size. We couldn't demonstrate non-inferiority of antibiotic corticosteroid ear drops, but what we could observe is that compared to the oral antibiotics, the topical antibiotics had a lower resolution rate of ear pain and fever at 3 days, a longer duration of parent-reported ear discharge, also slightly higher pain levels over the first 3 days, but with less total oral antibiotic consumption at 3 months and less gastrointestinal side effects. Yeah, why does this work not that well compared to the tubes? I think it's mainly due to the tear or the perforation which just closed and the drops cannot enter the middle ear cavity. I think that might be one of the explanations, and probably also the difficulty administrating the drops in this younger age group might also be one of the reasons. In the Netherlands, at least, current guidelines recommend to use oral antibiotics in this subset of children with AOM. I think this is still justified based on our trial results. So far.
All right. Very comprehensive, Roderick. Thanks. Lots to think about. We'll start with a Q&A. Dr. Thomas Schreffer has a question. Big problem of over and wrong diagnosis is lack of sufficiently trained PCPs. It's anxiety inducing. How many offices, especially in rural areas, are run by NPs? Any of the speakers can answer this one.
We've tried to train primary care providers using video training. I don't know that it really worked. During training, it's a terrible system, and we need to improve it, but it's not something you generally can get funding for, so that's a challenge. It's not something that's easily published, so that's a challenge. I think there's so much pressure on primary care providers to make a diagnosis of AOM in the context of a viral URI that the amount of time they spend actually looking at the eardrum is probably 1 second, and the amount of time it takes them to write a prescription for amoxicillin 1 minute. That works a lot better than actually trying to do an accurate diagnosis. So until we come up with a compelling reason why they should work harder at it, and a compelling argument with the training officials in our specialties, it's not going to happen. I'm sorry.
Yeah, I tend to agree. I think so. I think first of all, I think we tend to hold pediatricians on a pedestal. I think they're excellent diagnosticians, and that it's really an issue with our APPs. And we actually find our APPs fare the same or better than some of our pediatricians do. So I think that's important to recognize. About 30% of infections diagnosed by pediatricians are just wrong. But I think that the education stuff hasn't worked particularly well. It's hard to scale it. The digital otoscopy, I think, is an interesting idea. The problem is I don't think people will use it, right? Or I don't know that it's going to change behavior. So I think we'd have to see, would people use it? If they did use it, would it actually change what they do in practice, or are they just going to prescribe anyway? And then what we've had better luck with is there's a system called Dialogue around respiratory tract prescribing called DART that was produced by Rita Mangione-Smith out of WashU. It's free. And it talks about communication skills, and it increases satisfaction. When we have people do the DART modules, which are short, that actually seems to work much better. And it increases patient satisfaction, which is what they're usually worried about at the end of the day.
I don't think it's, Holly, thank you. I don't think it's going to happen, but if clinicians were required to take a photograph of the ear examination and put it in the electronic medical record, and that could be monitored by payers, that might make a difference. But I'm not sure it's going to voluntarily happen through our educational efforts.
Yeah, I think though the idea that we're going to get them to take a picture and put it in the EHR is about zero, right? So, but I think it changes it, right? Because like I think we all want to be optimists and say like the solution to the problem is to get people to use stringent criteria and to accurately diagnose ear infections. And it's probably not going to work very well. The solution needs to be to think about how do we roll out interventions, recognizing that most kids are not accurately diagnosed, and then have a safety net so the kids who really need it can still get the antibiotic. But the culture is that we routinely are not prescribing, and we're prescribing for the kids that are at higher risk for needing it.
Thoughts from other countries? Roderick?
Yeah, I agree. I think the diagnostic criteria and the Dutch guideline is fairly light touched, but I think in terms of when you are initially not prescribing, which is in the Netherlands more or less the case, then you can debate whether it's very important to have a really accurate diagnosis. It's mostly the problem of over-treatment and over-diagnosing, of course. So indeed, accurate diagnosis is important when you want to treat the patient well. But yeah, if it's a viral upper respiratory tract infection rather than otitis media, and you apply a watchful waiting strategy, there's no real problem. Instead, or you refer them quite easily to ENT for tubes because of the recurrent infections, which are not recurrent infections. Then you, of course, run into problems.
Is there anybody else in the audience who want to ask a question? Please speak up.
I saw one question about the desomedin drops.
Oh,
I
yeah.
think these are
That's for you.
antiseptic drops. Yeah. No, we don't have them in the Netherlands, but I want to stress that there is I think a really relevant trial who compared steroids alone versus steroids plus antibiotics versus antibiotics drops in tympanostomy tube otorrhea. And this clearly demonstrated that the antibiotics is needed because the steroids alone was far less effective than the antibiotics, and the combined drop was most effective. So I think there's added value of a steroid because of you reduce, you attack your inflammation. But I think the backbone of the medication is really the antibiotic in the otorrhea, treatment of otorrhea. And I'm also not sure whether it's ototoxic. So some of the antibiotics also, but mainly other types of treatment might be ototoxic. So I would also be resistant to use all kinds of antiseptics, etc. in the middle ear.
So Reggie, while we're waiting for questions, I'd like to have a little interaction between myself and the other panelists around the notion of trying to reduce the duration of antibiotic treatment of acute otitis media. I really embrace that idea, and I would suggest that the pediatrician and the parent needs a reason to do it shorter. One might be that it's a US phenomena because not every country gives 10 days. That probably won't work. But what we're working on, I wonder if the others would consider it. We're showing that every course of antibiotic has an adverse effect on the microbiome, with a secondary effect, for example, on poor responses to vaccination. So if you give both the parent and the healthcare provider a really good reason to use at least a shorter duration of antibiotic, I think that it would be more enthusiastically embraced, and we could diffuse some of the current folklore around the necessity for 10 days of antibiotics for the treatment of ear infections.
I think that this would be such a low lift that I think if we first of all change guidelines so that the short duration was recommended for most kids, people would do it. Our impression has been, based on how fast we see a change with these interventions, that people don't care what duration they prescribe, and the parents don't care what duration they get. And so a lot of people do it out of habit, right? Most of it's stemming from like the very old strep studies, around how long does it take to, get rid of strep when you swab somebody, that use 10 days. Yeah. So I think we could do it. But where we get hung up all the time is that the AAP guidelines have 7 days in there, which is really not based on evidence, right? So all the clinical trials that have used the same antibiotic in both arms have used 5 and 10 days. And there's some clinical trials that were not comparing duration, but those have included 7. But this 7, like, people will hedge and they will do the 7 instead of the 5, like 100% of the time.
Yeah, in the Netherlands, we also advocate 7 days. Although for pneumonia, it's already 5 days in adults. Yeah, from my perspective, it's more important to withhold antibiotics rather than shorten the duration. So I think that's the most important. So don't prescribe if not needed. And in terms of infection, yeah, we really have to review the evidence, because most of the times you compare 10 to 7 and then 7 to 5 with a non-inferiority margin, but might be that 5 is less than 10 in terms of effectiveness. So yeah, I'm not sure why using 10 days. I'm also not really sure why using 7 days, but I think no prescribing is more important than duration of prescribing from my perspective.
You're suggesting we reduce the duration to 0 days. I think we can all get on board with that for most kids.
No, at least it's about perspective, because I think in the Netherlands, I tend to advocate that you have to treat them well. So in the Netherlands, most of the GPs and colleagues think that you never have to treat an ear infection. So I think in practice, I treat quite regularly compared to my colleagues. But I think we have to treat the children who really need them. And I think due to probably also overdiagnosis of the condition, we now tend to overtreat.
All right, we'll take Andrew's question, but then we'll probably have to move on to the next session. Go ahead, Andrew.
Yeah, and my question was really in regards to how the transition in the Netherlands occurred toward watchful waiting, and any hypothesis from the panels on why it was more accepted there than it has been in the US.
I can at least say something about that. What I always experience is that, for example, the New England study of Hoberman, who also showed that antibiotics are more beneficial than placebo in young children. They have a composite outcome of the tympanic membrane. And when you look at the tympanic membrane and resolution to normal of the tympanic membrane, which might be an indication of clearing the infection, then you can argue that you have to treat them. Whereas in terms of symptoms, it really doesn't matter that much. So I think it's the perspective. I think also we know that there's evidence that you shorten the duration of effusion with antibiotics, at least if you have a strict diagnosis. And we also know that the tympanostomy tube rate in the Netherlands is higher. So it might well be that we treat less with antibiotics just due to cultural differences with countries. And we feel that surgery is more accepted. So at the cost of more tubes inserted, we treat less with antibiotics. And I'm still not sure what's the best balance, but that might also be one of the reasons.
Holly or Mike, do you have any response to that briefly?
I don't know if I have a good reason. I think part of it might be the way that, not that people always do what's in guidelines, which we clearly know, but I think part of it might be the way the guidelines are framed too, in terms of is the default immediate antibiotics, where some kids we recommend watchful waiting, or is the default watchful waiting, and then we carve out the kids who really need an antibiotic. So I think a reframing could help. I think the same with duration, right? Recommending the shorter duration for most kids, but these are the kids who really need the longer duration, I think is helpful. And then I think part of it is cultural, right? So we like to be very independent in the US, and that means that we're slow to change. I think that's going to get worse instead of better. The other thing that's interesting, I was talking to Paula about this from Finland, and she was saying that people are so afraid of autoimmune disease. There's been such an increase in the rates of autoimmune disease, like type 1 diabetes, celiac disease, that it's made parents a lot more hesitant to get antibiotics. And so she's often having to convince parents that they need the antibiotic as opposed to that they don't need it.
I think it's also when I speak to community-based pediatricians, the standard of practice is giving antibiotics. Even though I realize I could maybe not give antibiotics, if I don't, my patient is going to go to urgent care, or my patient is going to switch to a different pediatrician who gives antibiotics. So I think if in the Netherlands, the common practice is you don't give antibiotics, then everybody follows that. But in the US, I just don't see it changing where there's a floodgate of primary care pediatricians saying, we won't give any antibiotics. I think we got a much better chance to shorten the duration of treatment than we do to say everybody goes to watchful waiting. Thank you.
Yeah, I think that's a relevant point, Mike. In the Netherlands, we have also every patient is registered by a GP, which is OGP, and of course you can have multiple GPs in one practice, but you have to come back to the same GP. Of course, you can go to out of hours, but I think, and you can also have an appointment the next day again. So you can really apply the watchful waiting strategy, because you can say, okay, come back to me tomorrow. I'm here again. Happy for you to see you again. And if you know that's a relatively far proportion have a favorable natural course, you really can really also deliver this natural favorable course instead of people who have to travel for 3 or 4 days or have to wait for 3 or 4 days, which is now also in the UK happening. So it's really difficult to get an appointment by a GP. I can imagine that as you work as a GP and you know that they have to wait for 4 days, that you attend also as a GP more inclined to prescribe, because you don't want to have a worse course during your illness if you cannot have a safety netting there. So I think also these healthcare service delivery parts are very important.
I think part of this too is in the US, right? The family leave policies are really poor, right? So for parents, when they're going in the first time, they're taking off work to do it, often with financial consequences. If they have to come back or they have to stay home another day because their kid can't go to daycare, that's a financial burden. And then when you pay a lot to go into the doctor, you expect you're going to get something for it, right? So it's not very satisfying to get, to be told to do Tylenol or ibuprofen. Like you want to get the special thing that you can get only from the doctor.
Exactly.
I don't know that that's a problem that we're going to solve, but I think certainly
for free in the Netherlands, so you can just go to your GP for free. Yeah.
Right. Well, this is a really important topic, so I'll make a short plug. There will be a more extensive discussion with other countries too about clinical practice guidelines, including for medical management of acute otitis media at the International Society for Otitis Media in Philly in June. For those who are interested, you can also participate in that. And I think they're also preparing another session on diagnostics, new diagnostics that are powered by AI for with imaging. And so that wraps up our first session. Really, really thank you to all our wonderful speakers. You've enlightened us on a lot of things about medical management right now. That's changed quite a bit from the past 10 years, I believe. And so it's really important to think about some of the issues that you raised. I do encourage you to stay on because we are having a lab management session with Eric Harvill and Kalyan Dewan from University of Georgia. They are not just discussing lab management for the mentees, they are also showing their journey as a lab regarding what they've been doing for otitis media research. And so I hope that you stay on. Thank you so much for those who joined us for the first session. Anytime you can share your slides, Eric and Kalyan.
Thank you, Reggie. Yeah, that was a really useful, interesting, fun session. And I am going to try to tie in actually some connections because it seems like laboratory science is a relatively minor part of this. And I think there's good advantages to thinking about the different approaches, different strengths, weaknesses. Anyway, I'm going to try to tie in the connections and the positive interactions between the two. I will go ahead and share slide, I guess, but this is just kind of to guide the discussion. Or
Oh, I haven't introduced you. I should read your introduction. Sorry.
Sure.
Hold on. Dr. Eric Harvill is Athletic Association Distinguished Professor in the Department of Infectious Diseases, University of Georgia. He has served the National Academies of Science, National Research Council, NIH, NSF, DoD, other funding agencies, and is editor and reviewer for many journals. He studies the basic nature of the complex interactions between bacterial pathogens and the host immune response. The co-speaker for this session is Kalyan Dewan. He is an assistant research scientist associated with the Harvill Lab and has a background in biochemistry and microbiology. His work focuses on refining adult and neonatal mouse models of Bordetella infection of the respiratory tract and middle ears. Please proceed.
Great, thank you. Can you see my screen?
Not yet.
Okay. Yeah, you can.
No.
Yes?
Yes.
Okay, so so I'm going to give actually what I hope is most useful discussion for the mentees. I could have given a talk on, say, the mechanisms of the immunological mechanisms of protection within the middle ear and compare and contrast those to respiratory infections. That wasn't exactly what the mandate seemed to be. So I've tried to talk about what I think would be most important to a mentee who might consider starting a laboratory. And so I'm going to distinguish some of the things we do in laboratory kind of bench science, experimental science from the more clinical work that's been presented so far. So that's what I'm going to try to do. Who I am, so my background, my PhD was in immunology. My postdoc was in bacterial pathogenesis because my long-term strategy, and I'm going to talk about why this is important to have one, my long-term strategy for my lab was to combine the tools of bacterial pathogenesis, that is knocking out a molecular Koch's postulate, knock out individual genes, manipulate a bacterial pathogen to show how it is interacting with the host, and in our case, show how it is manipulating, how bacterial pathogens can manipulate the host immune response to their advantage, to either facilitate their infection, their persistence, their transmission to new hosts. And there's a long list of complicated ways that bacteria do those things that are still pretty poorly defined. But I wanted to do those studies, which are often use the host as a black box. They knock out a gene and put it into the mouse or the rat, and see how many bacteria they get back. And so they treat the animal somewhat as a black box. And so I wanted to, my strategy for my lab was to use a pathogen that really efficiently, naturally infected the mouse, and it had to be the mouse because only in the mouse are there all the tools of molecular immunology that make it possible to study and dissect in mechanistic studies, and I'll describe what that is in a minute, exactly how the immune system is working. So we can knock out every individual isotype of antibody, every cytokine, every cell type to see its contribution to controlling and clearing, in this case, middle ear infections. So, so that's my background. That's what I do. We use combination of bacterial pathogenesis approaches and mouse molecular immunology to define at the molecular level how the immune system interacts with the pathogen, how pathogens can and do very effectively manipulate the host immune system, and how in some cases the immune system can be induced to provide better protective immunity. But to do that, we first have to understand how protective immunity works. So that's what we study. So comparing, contrasting laboratory research to clinical research, there's an impression by people who I think are frankly haven't thought very hard about it. There's some competition, that these are distinct areas, and that and that they're competing with each other. And I think that's naive. They're both vitally important. I mean, we can't understand the problems well without the clinical research that's been described here. And some of the proposals, such as those that Mike Pichichero described regarding the differential immune maturity or immune functions being involved in predisposing to otitis media. So those are the kinds of questions that that need to be generated in these kinds of clinical studies, and then can guide the full force of laboratory molecular immunology in the mouse model to identify the details. That is a specific cytokine profile that predisposes to a particular type of ear infection that's also linked to respiratory infections, relating this back to Mike's talk. It can be dissected to the molecular level, and then that can in turn guide improved clinical approaches to dealing with those. So each laboratory and clinical science have their different strengths and weaknesses. I'll mention key ones in a moment, and each informs and supports and guides the other, and then both are critically important. And either one of them trying to operate in the absence of the other is just willfully blinding yourself to a lot of what's important. So what are the key weaknesses and strengths of lab research as opposed to the clinical research that has been spoken about? First of all, mice are not humans. So that's sort of self-evident. Having said that, most of what we know about immunology nowadays was initially shown in the mouse model. Most of it is confirmed. Where there are differences are super interesting and important. But most of what we know about immunology, indeed the vast majority of it, was shown in the mouse model initially, and nearly all molecular level advances in immunology are discovered in the mouse. So it's possible to test hypotheses such as those proposed by Mike at a mechanistic level in mouse studies that just aren't feasible in human studies. So, so I said that I was going to mention the strategy for starting my lab, and I gave the example of how of the strategy I started out with in my lab. And this is, of course, geared towards guiding mentees who might be interested in running a laboratory more like mine rather than a clinical study more like some of those previously presented. So some key considerations that are a bit different are setting out to become independent, run your own lab, manage your own lab, requires a separate path. Pardon me, it's windy and the shades are blowing into my face. So one would not want to be in direct competition with one's mentor when starting off on the own for a long list of reasons, including collegiality and friendliness, but also just sheer competition would be difficult. Understanding the significance of the problem and being able to communicate the significance of that problem, making compelling hypotheses, such as the maturation of the immune response is and differential maturation is involved in the susceptibility of some to otitis media. That lends itself to specific hypotheses that can be tested if one has an assay system. So my PhD mentor taught me that all of immunology is assay driven, and indeed all of biology is assay driven. In order to study something, we have to be able to measure an effect, and then manipulate conditions and measure how that changes that effect. So one particular aspect of laboratory research is that a powerful experimental system in which you can measure things accurately with a very high signal to noise ratio and statistically robust conditions is really important. And then, of course, it arguably should be number one in terms of importance is being able to recruit and manage people. A large part of the job of running a research laboratory ultimately becomes managing and training the people, especially in an academic environment where that we are our biggest job is to train students, postdocs, undergrad students, grad students, postdocs to go on and do their own research. So that's kind of the preface to Kalyan. He's going to talk a little bit of detail about some studies, but that are particular to our lab. But I wanted to give this kind of broad overview of what's distinct about and address the mandate to talk about lab management here first. And I guess one last thing I'm going to say is that as I said, my background is molecular immunology, bacterial pathogenesis. We a little bit stumbled into otitis media because we discovered bacterial pathogens that naturally and highly efficiently ascend both eustachian tubes of every mouse to cause otitis media in every single mouse. That's the kind of assay system in which you can study in detail how that happens, how bacterial pathogens ascend the eustachian tube, the process of colonizing, the process of inducing symptoms. In some cases, in some organisms cause chronic otitis media that never resolves and completely degrades the entire middle ear and the bones associated with it in the inner ear, such that these animals are definitely death for life, and never clear the infection. And other organisms, different species, that does the first few things, highly efficiently ascends the eustachian tube, colonizes the middle ear, causes otitis media, but then is resolved. And that's really important because then we can study the immunological mechanisms involved in clearing infections from the middle ear. And Kalyan will show you how we can already, in our first kind of early days of studying it, distinguish the immune responses under those two very different situations, and identify and define exactly the immune mechanisms that are involved in controlling and clearing the infection. We can knock out specific immune mechanisms and show that those are required for controlling infections. We can induce them, we can adoptively transfer them from an immune animal to a naive animal and show that we can confer protection that way. So Kalyan's going to give you some examples of that now.
Okay. Eric, will you stop sharing and then I'll start my share? Yep, thanks. Yeah, just to reintroduce myself, Kalyan Dewan. I'm an assistant research scientist working in the Harvill lab. I've been here for about 6 years now, going on to my 7th year in this lab. And I was discussing with Eric about how would a lab management discussion, how would I present something like that? Because I've never really done this before. So he advised, just describe what you're doing, working on the bench as a colleague and a mentor, So I've taken that sort of prompt and carried on from there, okay? So of course, I start with streamlining the objectives of all the projects running in the lab with Eric, okay? And being almost a representative of Eric in the lab, and how I conduct my interactions. I mean, there's a whole grade of students there from high school, undergrads, grads, postdocs, collaborators, they're all coming in from all directions there. But the fun thing about this is I get to see the maturation of these young adults into like full adults, let's put it that way. So I see a lot of transition in the course of their studies. I mean, they come in as just starting to vote. They get to drink alcohol along the way. Some of them get engaged, married. So it's a fun thing that way. But they all need different gloves to be handled, right? So that's what I say. The main thing I just want to highlight here is in undergrads, the takeaway messages by the time they complete this course of work in the lab, association with the lab, is that undergrads learn that research is demanding. It's very exacting. You've got to pay your dues. It's nothing that when they first come in. I mean, they have very grandiose visions of research, but then they get to learn that it is demanding. You've got to pay your dues there. The graduates, they're coming with some sort of maturity in them. I mean, they get to learn that research is costly. It's collaborative. You're not the lone star in the field there, So you've got to come to terms with these things. It's costly. You just can't perform all the experiments that you can conceive of. The lab may not have the necessary experience or the expertise, so you've got to reach out. There's got to be a lot of collaboration, a lot of sharing. And of course, as postdocs, I mean, this is the crunch there. Research is competitive, particularly in the field of otitis media, where it is a sort of a somewhat contracted field. What do I say? What do I say? What do I do with these, these different groups of students, your people, your trainees? So in the undergrads, it's normally introducing the milieux, rather as an extension of the respiratory tract. Hey, there's this thing, otitis media, look into it. It's not just lungs. And that's what they get over here. So they get to look at what's happening in the ears in relation to the respiratory tract, and they sort of begin to conceive of, a field of study. That's where it comes. For grad students, it gets a little more interesting because you're studying middle ear infections in conjunction with respiratory tract infections. And of course, the pathogen we focus on as Bordetella. And this is, I think, very much what Mike was talking about. It's sort of like looked at it together, middle ear otitis media, rather than in isolation as an independent organ there. And for postdocs, of course, it's really sort of like, taking along with them to wherever they get their postdoc appointments, take along with them an experimental system in respiratory tract and middle ear infection biology. So that's the sort of course of the passage of these students through our lab. And of course, my management, so-called management sort of role would be, of course, facilitating this process, and just, participating with them in the experiments on the bench, in the discussions. Okay, so now I'm going to move on just briefly. I know we're running way over time, about the experimental systems that we have with which we are, engaged with. So the first one is Bordetella pseudohynsia, one of an environmental species. And what we noticed is that they are chronically infecting the middle ears, and that's over here, right on the far side, okay? This is a study that's extended up to 100 days. And we see that in contrast to the trachea and the lower respiratory tract, where there's a sort of, it's just flickering down there, the middle ears of all the mice are like consistently infected and persistently infected. Not only that we also found out that, infected mice, if you put a primary infected mice, mix them up with naive mice, there's transmission taking place of the pathogen across to all the naive mice. And this is after a 21-day sort of exposure co-housing sort of scheme. And all the naive mice were infected. So we see that, otitis media can actually, chronic sort of infections of the middle ear can sort of be transmitted across. Of course, this is the basic system. There are so many questions that one could use with this sort of relatively questions to be studied, using the system. For example, the antibiotics, presentation today, which is so interesting. There is, plenty of space to look at delivery systems and, extend that onto transmission, inhibition of transmission. Yeah. So, but it's all in conjunction, of course, with the upper respiratory tract infections here in the nasal cavity and the trachea, where all of them are there. It's not so much the lower respiratory tract here. Okay. And one important thing to mention here is that these are sort of natural pathogens. So we just need to put in about 100, 150 CFU bacteria in a few couple of drops and just in 5 to 10 microliters into the nose. And then the infection takes hold. So if you can see the initial first day sort of colonization load in the nasal cavity is way down there. And it just takes hold, it just grows, robustly. We also know that this pathogen is not a lower respiratory pathogen here. So it just does not move to the lower respiratory tract, but gets into the upper ears and into the ears here for sure, okay? So that's the sort of system for Bordetella pseudohynsia. This is the second species, Bordetella bronchiseptica. In this case, what we find is that even with low sort of inoculation doses, yet the C57 black sick wild type mice, they also get into the nose, they grow robustly, but then and the middle ears too, along with the nasal cavity, not the lower lungs, but then they are controlled, right? It's the same sort of similar 100-day study. So here we have sort of a model for an acute infection of the middle ears, right? And as Eric was alluding to, so you can look into the host immunology here too, because we did the same infection study with B-cell deficient and T-cell deficient mice. And of course, this is what we saw. We saw that both the B-cell compartment and the T-cell compartment are required to control the middle ears here. So straight away, this leads us into the more deeper questions of humoral versus cell-mediated immunity. So those are the questions that are poised to be answered. And finally, I think we have one more. This is the neonatal infection system. Okay, of course, here it's always important to talk about define neonatal system. There was a publication from this lab, Colleen Sidney, who just completed a PhD, successfully defended her dissertation 2 months ago, about 2 months ago, where she found that, the susceptible period of neonatal mice, appears to be P5. P5 stands for POP5, the day fifth day following birth, okay? And she sort of investigated the sort of ages, different ages of mice after birth, and found that P5 seemed to be the limit beyond which, up to which, the neonatal mice were very, very susceptible to infections, that the infections really, picked up. Beyond P5, there is evidence to show that, there is some aspect of control coming in. So from P7 onwards, from day 7 after birth onwards, there seems to be some control that these mice, growing mice, are able to sort of like, have developed, let's put it that way, okay? So this is important because, we're talking about mice, and as Eric said, mice are not humans. So clearly defining that period of susceptibility in neonates, right, in the neonatal model, becomes sort of the foundation of the system. Up till now, nobody's really looked carefully at neonatal mice in that perspective. So P7, they start infections at P7. They wait for 3-4 weeks to look at that. That has some use to it, but for the specific questions of neonatal vulnerability, I think that's sort of a little beyond the scheme, the time frame that we've really identified here. So this is this is the publication, PM the ID for the PubMed publication there. And this is the infection dose for the neonatal model. This is a high dose infection, okay? So it's 10 to the power of 4 CFU delivered in 15 microliters. These are small animals, so 15 microliters generally sort of saturates the lungs. Gets into the lungs for sure, okay? So this is what we see using the high dose model. So it gets to the nasal cavity, and this is the day of weaning, okay, day 28. After day 28, the infection is controlled, but here, the middle years, it seems to persist for a while, And that's one aspect of this infection system that we're looking at. Is this artifactual? Is it, relative to humans? So there's still those basic questions to be answered. Okay, but what's for sure is that, we can easily study the factors involved using this neonatal system, bacterial pathogenic factors involved, because when you look at the inflammation over here on the PBS, the challenge with PBS, nothing. When you put the pertussis wild type, you see the inflammation starts getting scored. But if you delete the pertussis toxin, the main toxin of the pertussis, then we, see that the inflammation is controlled again. So we know that, pertussis dependent infections of the middle ears and the respiratory tract is happening there, okay? And this inflammation is sort of middle ear specific, okay? So that's one thing. What else have we got there? Yes, this is another question we also asked, as I said, for Bordetella pseudohensii and Bordetella bronchoseptica, I was just using very low doses, right? Just 150 CFU in 5 microliters. So we wanted to look at a sort of neonatal low dose model. Okay, in this case, we took about 250 CFU in 3 microliters, right? So doesn't come in as a one big bolus, challenge. So this is 2 hours, 3 days, 7 days, 10 days in the nasal cavity. And this is what's happening in the ears. Okay, this is a combination of both the left and right bullae. So it seems to be correlating. It definitely gets into the ears. Okay, it seems to be correlating with the increase in the nasal bacterial load in the nasal cavities here. So for sure, we can see this. We can sort of investigate these things here now. Is what we feel that the bacterial load in the nasopharynx may actually be pushing stuff into the ears. Okay, but it seems to be quite consistent there. What else have we done? Oh yes, this is another thing. We've done maternal vaccination. We found that that's protecting against pertussis infections of the ears quite well. This is again the P5, day 5 pups. They're born from vaccinated dams, vaccinated mother mice, female mice. This is the high dose infection at 3, and we're checking it at 3 days post-challenge, okay? So this is the PBS vaccinated mothers, and this is the whole cell vaccinated mothers, whole cell vaccine. Okay. And we see quite robust protection going on. I don't know where the significance went in there. I think there's 3 stars there. So medial ears are quite robustly protected. So there is a transfer of protection from maternal vaccination onto the ears. Okay. Yeah, so those are the main models we have right now. And I just want to finish off by just concluding that we have now quite well-established, we feel well-established natural infection models of persistent and acute otitis media. We're moving into neonatal systems to look at that. But of course, as Eric mentioned, define the mechanistic questions to be examined. And I guess the presentations, the gatherings like today are so helpful, in defining these. Of course, because it needs to be guided by clinical priorities for sure, especially with the funding, sort of like, the difficulties in funding for this very small, but, very important field.
If I can just add one final comment that ties it back to where I started. So the synergy between clinical research and laboratory research is super important. So the questions, for example, like Mike Pichichero identified, promoting the idea that differential immune development is involved in the susceptibility to otitis media. That's something that it would be very difficult to test in humans in a mechanistic way. Lots of correlative studies that he's done are great for identifying those kinds of questions that can really be addressed mechanistically in the mouse model, meaning we can go in and turn off immune functions, turn on immune function, delete them, add them exogenously. To really define exactly what the mechanism of protection is. So the synergy between the 2 approaches is super important to recognize and think about. And I know we're way over time, but if anybody wants to send a question to me independently outside of this forum, feel free.
I'd like to comment. First of all, thanks for taking this on, Eric and Kalyan. Lab management is not easy. It might be very personality or group dynamic dependent, right? It depends on your leadership style, but it is something that came up in our needs survey previously that is needed, especially for a mentoring network. How do you handle different groups at different levels? And I think your slides were spot on. And just a comment, because I was trained in a mostly in silico analysis lab, not an experimentalist lab. Some of your thoughts apply directly to how it goes, even if instead of the wet lab benches, you have mostly computers and people. And it applies also to clinical research, except that maybe you have clinical research coordinators instead of people doing analysis. So those thoughts are important, especially you're addressing it to more of the senior mentees who might want to start their own research, and how you close it up to in relation to the clinical talks earlier. Also parallels. It's interesting what you're seeing in the mouse models versus what they were reporting, right? It's uncanny. It's really nice. Is there anybody in the audience who would like to comment or ask a question? Please feel free to do so.
Those were really good comments. While people are raising their hand, I'm just going to say one thing about that. We could talk for hours, days about managing people, and take an entire management degree. But one thing that boils down to, for me, in academia at least, is to make it about the student. So viewing leadership as a leader as coach. So if we are lucky to be entrusted with the mentorship of some promising, talented young young people and have the benefit of getting to watch them develop into the best scientist, physician, whatever they want to do with their lives. And the more we make it about them, the more everything is there's going to be good agreement between the mentor and the mentee. When mentors can make the mistake of getting caught up and think about themselves and their publications and their grants and what their needs, and that's a rabbit hole, and it's not as good a way to make the job as fulfilling and happy and productive as it can be. So just focusing on the student and their development. Mike, I'm still here.
Yeah, Mike.
Reggie and Eric, I want to echo that. Hopefully you get to a stage in your career where you're not as worried about your own publications and grants, and you're able to transition and be focused on who you're mentoring. That takes a little bit of time to get there, but once you get there, you should try to make that transition, because as Eric, you just pointed out, it actually reaps huge rewards for the science, for the mentee, and for the mentor. I would add that in my group, we create metrics. We sort of know when you're sitting in study section, you're looking for a certain number of manuscripts by that particular applicant, right? First author manuscripts count way more than being fifth in a 27 author. So we give metrics, 3 first author publications per year. Within 2 years, you need to be writing a grant. And if you don't get it funded, let's keep working. You work with your mentee to give them metrics that we know are the metrics of success in academia, publications and grants.
And coaching them to succeed in that area is a super rewarding job. It's a great job, actually. Once you can settle into just focusing on the students, it's my whole life is much better. I was taught, early in my career and thinking about myself and my own needs, and that just, and I see it a lot in young investigators. They have some pressures, and but the more they can set those aside and focus just as being a coach, the better for everyone.
Well, just another brief comment before I call on Guillermo. Coming from the genomic space, I would say around 90% of our current PhD students are angling for industry jobs, not academia anymore. And so it becomes harder for me to convince them that they have to meet those metrics, because they know that that's really more towards academia. But I do know that if they're applying for jobs, the papers that they write, what type of studies they're doing, that really matters in the job market, especially as it heightens, it becomes more competitive. So that becomes a motivation for them too, that they still need to churn out products that would serve them in their careers. Not necessarily helpful for me, but more for them.
One way I make that real for my students is I tell them, and I show them evidence to back this up, that every additional paper they publish during their PhD adds 10,000 to their salary when they leave for life.
Wow, that's a nice estimate, Eric, but I think it's a good one.
Yeah, I want to voice that. Yes, Eric. About half of the people I've mentored, I'm now at 62 mentees. About half went to industry, which is fine. That's great. But do you want to go in on an entry-level job, or do you want to go out in as a group leader? Every publication and your ability to get one independent grant elevates where you enter into the industry management hierarchy.
That's your trajectory for everything thereafter too.
Thank you.
Yep.
All right, let's call Guillermo. Guillermo put questions in the chat. Maybe you want to ask yourself.
Sure.
If you can
Yeah,
unmute.
I didn't know if we had time. So yeah, hi Eric. Thanks for talking, and Mike for your comments. Really appreciate the student focus. I 100% agree. So yeah, my question was so when running a lab for either of you, your time is split between, especially for myself, I'm looking ahead. There's grant writing, mentoring, logistics, teaching, all these different things. What's your biggest tip on efficiency? For example, someone told me that being satisfied at 80% probably means you're doing okay. and then you can maybe, let that go and do something else. So you're not just stuck trying to get everything perfect. But yeah, what other tips might you both have for that?
Time management and managing all those different responsibilities is a huge part of the job, and I can't give you a short answer to that. I mean, different things work better for different people. Maybe Mike has something that he thinks is a generally helpful to other people. For me, it's been limiting how spread out I am. It's identifying the things that I want to focus on and not going off on tangents, but staying pretty close to home on projects that I know we can publish on. I know we're going to help my student move forward.
Yeah, it's along the same line. It's prioritization. So meeting with the people who you're leading, I do it once a week and at least, and say, okay, you have multiple options here, but which one is the most important for your career development? Because yeah, you could do that, but where's that going to yeah. So for me, it's prioritization, and it helps a younger investigator because they get excited about too many different things. You got to stay focused, list your priorities. If they go off on the wrong, you got to bring them back. It's not that it isn't a great idea, but here's your metrics. Let's stick with those.
Where are you going to publish that? Who's your readership? Who's gonna care?
Yeah.
If you can answer those questions, then great, you can do whatever you want.
Did you want to chime in, Kalyan? I thought you were going to say something.
No, I was just agreeing. Yeah, who's going to be your readership, and who's going to be impressed? Who cares? Who's going to care about it?
Did that answer your question, Guillermo?
Yeah, thank you. Someone's phone's buzzing, I think. Thank you for your response. It's just a question I often ask because, as you said, there's so many different circumstances and situations. Sometimes you get a pearl of wisdom, and that's it just sticks with you.
It's a good question.
Prioritization.
Yeah, and Mike, you had something else. Sorry. Oh, sorry. All right. There's a question from Jillian Hurst. Do you have any tips for finding good people for your research group?
Ooh, so that's a really big, important question, and I've made mistakes in the past. And what I've come around to thinking about during, we have a rotation period of 5 weeks, and what I evaluate in those 5 weeks are, yes, it's important they're intelligent, but they're all smart if they made it into grad school. Really more important than that are, are they cooperative, collegial, and are they coachable? Like if my strategy is to act as coach and to coach them, not everybody is as coachable. Not some people just want to be told what to do, and they might be successful in some other lab, but in my lab, I'm guiding them. I'm not telling them what to do on a daily or weekly basis. I'm evaluating what they're doing, and they've got to lead it themselves. So they've got to be ambitious and want to be successful, and they can communicate. You can look for this because they'll communicate with some passion what they want to accomplish. And then they have to be coachable. They have to be willing and looking for feedback. And there are people who are just not sadly, not self-confident enough to come and ask questions. And it's harder to coach somebody like that. So that's kind of a little bit vague, but it's a little bit reading people and a little bit knowing yourself and how you interact with people and making sure you're comfortable working with this person, that they're going to listen and to your guidance and work with you to improve.
I would take it, thank you, Eric. I would take it from a different angle to complement what you said. So you get people who apply for a position in your lab, and after you kind of make your own mind up whether it might work, what's the next step? The next step is when they visit, they meet with the other people who they're going to work with, and they get a pretty good impression of of your lab and who those people are and whether they're going to be able to work together. And they also get an opportunity to ask the people who are working already with you, how happy are you? How good of a mentor is this person? And though if those answers are all positive, you tend to have the applicant wants to come. So that's the other part of the earlier conversation that Eric and I had about if you give quality mentoring and you walk out of the room, you can be pretty sure that the people in your lab are going to say to this applicant, this is a great lab and we all help each other. And Dr. Harvill is an awesome mentor. That's what you hope is going to happen.
I got a second, and I've got to say it was an oversight for me to not say this. And this is kind of like I treat it like my low bar. Like I don't even consider someone until the other people in the lab tell me, yeah, that's the one. We can work with that person. Yeah, she fits in. She's she listened. She followed instructions. She came and asked questions. So that's kind of they've got to hit that bar. But it's a super critical bar that I didn't mention. They've got to be cooperative and collaborative with the other people in the lab.
Yeah, I'll just add to that, Eric. I mean, provided there is this rotation system where, all labs get to sort of interact with the potential sort of candidate coming in, I mean, the feedback is quite rapid, from the current members, and that sort of determines a lot of things, how they're going to interact, because everything is interactive here, and we ask each other's help, and so yeah, it's not very difficult to sort of like predict. For the most part, it's going to be quite accurate, the predictions, but you might miss a few really misunderstood students who may be great, but I know that's where you got to make the call, I guess. So.
Yeah, my lab is younger than Eric's or Mike's. I would just say when you're starting out, you might not be known, and some of your applicants, it's not going to be a big pool because they would, of course, gravitate to the well-known labs, the bigger groups. But you still take the best of who's applying, and hopefully, you just try your best to train that person, and if they can stay long, then they can help you establish your lab. Just a different perspective if you're just starting out, because that's going to be a different flavor when you're managing a lab. Guillermo, you had another question? That might be the last one we'll take.
You just answered it, actually, Reggie. Thank you.
Yeah. So it's not easy starting out. My first lab person did not actually have much lab experience. She was working at a fast food restaurant when I hired her, but she stayed in the lab for 5 years, and that was a good experience.
That's good to
Yes,
know. I was the
Julian?
first grad student in my lab, and so I know what it looks like from that end, but I'm like, man, that could have gone really badly if I'd been crazy or something.
Yeah. Well, thank you for
thank
that
you.
question. Yes. And thanks everyone for staying on. We really appreciate your attendance and your participation. Hopefully you can come again when we have the next session in January. It will be on biofilms with Lauren Backlitz and Earth Garlic. And we'll have another session with the mentees and mentors. We'll just make announcements sometime when it's coming close. Thank you so much. This will be the last for the year. And I hope you have a good December. Not too cold in some places and not too warm in some. All right. See you. Bye-bye. Thank you.
Mike and others, have a good day.